Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health. I'm Joshua Sharfstein, Vice Dean for Public Health Practice and Community Engagement, and a former health commissioner here in Baltimore. Our goal is to bring evidence and experience to illuminate critical public health issues. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
Hi, I'm Lindsay Smith Rogers, producer of Public Health on Call. Today, on Indigenous Peoples Day, Dr. Donald Warren, the new co-director of the Center for Indigenous Health at Johns Hopkins, speaks with Dr. Josh Sharfstein. They discuss the opportunities and challenges for health in tribal communities, as well as what Indigenous health as a field can offer to the world in 2022. Let's listen.
Dr. Don Warren, thank you so much for joining us on Public Health on Call to talk a little bit about the new Center for Indigenous Health here at the Johns Hopkins Bloomberg School of Public Health.
Very happy to be here. Thanks for inviting me.
So maybe it would help just for you to introduce yourself a little bit to our audience. You've had an incredible career.
Well, thank you so much. Yeah, my name is Dr. Donald Warren. I'm Oglala Lakota, originally from a small town called Kyle, South Dakota on the Pine Ridge Indian Reservation. And I've been working in various aspects of healthcare for my whole career. I went to Stanford for medical school and finished medical school in 1995, and then did a family medicine residency and worked for a number of years as a primary care doctor with Indian Health Service and the tribal programs. But what I found is that so many of the things we were dealing with in the clinic were preventable, and we're not going to prevent things like diabetes in the hospital. That really has to be done in the community. So that's when I switched my career toward public health. And I was very fortunate. I was able to do the Commonwealth Fund Harvard University Fellowship in Minority Health Policy and get my Master of Public Health from Harvard School of Public Health back in 2002. So over the last 20 years, my career has really been focused on trying to improve Indigenous health through education programs, community-based research, and program development designed to promote health and prevent disease in Indigenous populations.
So could you give an example or two of the kinds of programs that you've worked on to improve the health of Indigenous people?
Sure. So I did work on the Diabetes Prevention Program, the DPP, and that was a multi-center study that was started in the late 90s and went through the early 2000s. And through the National Institutes of Health, I was actually a staff clinician with the National Institute of Diabetes, Digestive and Kidney Disorders, and they have a Phoenix Epidemiology and Clinical Research branch. And out of that office, we conducted the DPP in several tribal sites, including Shiprock, New Mexico, Zuni, Pueblo, Gila River Indian Community, and Salt River, Pima Maricopa Indian Community in Arizona, as well as the Phoenix Indian Medical Center. And one of the wonderful outcomes of that is that we were able to show very clearly that the best way to prevent diabetes is through appropriate lifestyle interventions. It was even more effective than using diabetes medications. So for a public health perspective, it's just wonderful to see that these things that we had been encouraging people to do over the years could be borne out scientifically in the research process. So what that tells us is that we need programs and policies that make accessing healthier food much easier. We need to make the healthy choice the easier choice. And unfortunately, still in many tribal communities and other underserved populations, quite often the healthier foods are more expensive and people are priced out of making healthier choices even when they want to. So that's been a whole area of work looking at food access and making sure that we're promoting health through appropriate policies and program development.
And that diabetes prevention program is now available to a lot of Medicare beneficiaries around the country, not just in tribal communities, to prevent diabetes.
Exactly. So there was a multi-center trial, and we did oversample the American Indian population just because our population is so small. But it was a national study that involved multiple populations across the country and was really, I think, quite a victory for public health, just showing that we don't need medications to prevent diabetes, that there's other ways that we can promote health.
Now, when you're doing a study like that, or in your work more generally, are you taking exactly the same intervention that may be thought of for a different population and applying it on reservations or in tribal communities? Or are you trying to adapt interventions for the environment and culture of the groups that you're working with?
In an ideal setting, we're adapting evidence-based practices, and that's been a struggle with a lot of the funding agencies and working with national programs, whether it's through CDC or SAMHSA or other federal programs. They want us to use evidence-based practices, which makes a lot of sense. But my question is always, whose evidence is it? If something works effectively in Baltimore, that doesn't necessarily mean it's going to work effectively in Kyle, South Dakota. So we also have to take into account what are the local assets and local resources. So if we're making diet and exercise recommendations, we have to make sure that we have access to those things in the communities. And just as a very quick example, when I was a clinician, I also became a certified diabetes educator. And looking at special populations with diabetes, for example, those with arthritis, they were making recommendations for water aerobics and swimming. And that's wonderful if you have access to a swimming pool. But of course, on our reservation communities, we don't. So we can't just assume that a program that works effectively in a city or a suburb can just be plopped into a reservation or other underserved population and be effective. So we have to be very flexible and very wise in public health practice to recognize that we have to leverage the local assets and resources in order to modify evidence-based practices appropriately.
Now, you mentioned some of the obstacles to good health, not having access to healthy food, maybe not having access to recreation like swimming pools. So in your work, you are trying to work around them sometimes and figuring out how to modify interventions. But I'm sure you've thought of the fact that there are these structural impediments to good health that certainly affect a lot of tribal communities. How do you bring that into your work in Indigenous health?
Well, from a couple of perspectives. One, we do have a lot of impediments and challenges, and certainly poverty is one of them. And many of our tribal communities are also very rural and isolated. So we don't have local access to many things that we might take for granted when we live in a city. So we have to recognize that there's those challenges. But on the strengths-based side and the resilience of our communities, we also have other strengths that are unique as well. So for example, cultural connectedness, participation in traditional ceremony, and even language preservation have all been shown to be effective ways to promote health and are protective against negative outcomes of some of our social determinants of health. So I think in addition to addressing those impediments and challenges, we really need to be leveraging the strengths that are within our populations. And there's some limited studies that demonstrate this, but what I'd love to see coming out of our center is much more broad-based research and interventions that's really leveraging the strengths of Indigenous populations.
So you have come to Johns Hopkins as the center is getting renamed, now the Center for Indigenous Health. What do you hope that this field can accomplish?
Well, first, I'd really like to acknowledge the longstanding history of the Center for American Indian Health, and that's been in place since the early 1990s. And a lot of the work from Dr. Matu Santosham and the work that he did with several tribes in Arizona. But over the last 30 years, the field has really evolved, and we're seeing some significant comparisons and similarities across Indigenous peoples worldwide. As an example of that, I was actually presenting at the International Diabetes Federation back in 2003, and this was being held in Melbourne, Australia. And I was on an Indigenous diabetes panel, and there was a speaker from Australia, a speaker from New Zealand, and myself, and we're all Indigenous academics. And it was really remarkable. We didn't coordinate ahead of time, but we each gave essentially the exact same presentation with the exact same data, even though it's different populations, different parts of the world, and different histories. But the impact of colonization really is ubiquitous, and it has an impact on things like marginalization, cultural connectedness, loss of food sovereignty, and loss of traditional lifestyles. So when we think about the work that needs to be done from here, of course, we cannot reverse the history of things that have happened, but we can try to create a better future for Indigenous populations. And I think there's so much work to be done in terms of identifying what are the strengths that can be and should be leveraged, and how might we best work within our very diverse health systems internationally to promote health and prevent disease for Indigenous peoples. So moving forward, I'm very excited about the work that we can do with our international colleagues.
That I understand will be a focus now of the center's work, and hopefully create new opportunities for insights and collaboration to promote Indigenous health here in the United States.
Absolutely. I think that there's so much work we can do here in the US, and we could do similar types of programming in other parts of the world. And one of the things that we're discussing is developing an Indigenous health database. So we have some databases like BRFIS, the Behavioral Risk Factor Surveillance System. And we historically have had limited participation from American Indian populations here in the US in that database. But what I'd really love to see is a database that includes those types of questions on the Behavioral Risk Factor Surveillance System, but also add additional questions that are more focused on Indigenous populations, like measures of historical trauma or family or personal experiences with the forced boarding school participation historically, and things like adverse childhood experiences. But then on the strengths side, measures of language preservation and cultural connectedness or participation in ceremonies. So we could start to make more meaningful correlations within the data to understand what are the risk factors for our people, but even more importantly, what are the strengths that we can leverage to improve outcomes.
And you could also track the results of interventions to grow those.
Exactly. So we don't want to just kind of sit in our office and think about what might be a good intervention. We actually need to use data and science to understand these things. So I think in addition to getting the data to understand the disparities and the risk factors and the strength-based factors, we also need qualitative data. We need to hear from the community members regarding their perspectives on the best way to prevent disease and promote health. And then based on those data, we can then develop appropriate interventions and measure the impact over time. But it's going to be so important to have that baseline data. So
on Indigenous Peoples Day, there's a lot to reflect on, the terrible history of genocide, the trauma that many people have experienced. But it isn't entirely a day for looking back. And as you think about looking forward, the work that you do, what do you want people to understand about Indigenous health, and what keeps you so focused on the promise of what can happen better in the future?
Well, historically, when we look at human populations, the Indigenous peoples are the original inhabitants of various parts of the earth. So here in the US, of course, the American Indian and Alaska Native population are the Indigenous North Americans. And we can't forget about Native Hawaiians as being the Indigenous peoples of Hawaii. But I think by having that deep-rooted sense of connectivity to place and the sacredness of place and that deep-rooted cultural and spiritual connectedness to the earth and the natural environment, I think that by promoting Indigenous health and reviving in many ways those strengths of culture that integrate the natural world with health, I think that could be benefit to all populations, not just Indigenous peoples. And when we look at some of the challenges we're facing right now with climate change and environmental degradation and outcomes like terrible hurricanes and fires and floods and droughts and all of these things, I really believe that the solutions to some of these national and international challenges will come from Indigenous belief systems and practices. So I see this as being of benefit to Indigenous peoples, but really of benefit to all people.
Well, Dr. Warren, thank you so much for coming to Johns Hopkins, for your incredible work to date, and for the vision that you bring to this incredibly important challenge.
Well, thank you so much, Josh. And I look forward to further discussions, and I appreciate all of your support in terms of my opportunity to be here at Johns Hopkins.
Public Health on Call is produced by Joshua Sharfstein, Lindsay Smith-Rogers, and Stephanie Desmond. Audio production by J.B. Arbogast, Holly Cardinell, Spencer Greer, and Matthew Martin, with support from Chip Hickey. Distribution by Nick Moran. Production support from Catherine Ricardo. Social media run by Grace Holes Fernandez and Amber Bryan Singletary. Thank you for listening.